everyone. I'm Katrina Allen, Head of Alumni Relations and Regular Giving here at the university, and I'm really pleased to welcome you all to our special event for graduates from the School of Medicine, Medical Sciences and Nutrition. Before I hand over to our colleagues from the school, I first need to cover a little bit of housekeeping for the event. Firstly, you may have noticed pop-up notifications on your screen when people join or leave, etc. Unfortunately, we can't turn that off for everyone, but you can turn it off yourself, and my colleague Nicole has put up a slide with some instructions on how to do that. If you haven't done so yet, if you click on the purple icon at the bottom right-hand corner of the screen, this will open up the Collaborate panel, then just follow the steps on screen to change your notifications. As you'll have noticed, the option to use the camera and microphone has been switched off for attendees for now, but it will be switched on for the Q&A should you wish to ask a question in person. When we do that, you will see a camera and microphone icon appear at the bottom of your screen. Should you wish to ask a question aloud during the Q&A, please use the raise hand option that you'll find at the bottom of your screen so that we can call on you. We do ask that you keep your camera and microphone switched off unless it's your turn to ask a question. Alternatively, you can use the chat box at the side to ask questions at any time. It's also found in the Collaborate panel by clicking on the purple icon. You can submit them anytime you like, just type them into the chat box and Nicole will read them out during the Q&A portion. We only ask that you keep your questions clear and concise. If you need any assistance throughout the session, please use the raise hand option at the bottom of the screen and we'll reach out to you via a private chat message. And finally, just to note that the session will be recorded and shared online. Okay, that's quite enough from me. So without further ado, I'm delighted to hand over to the head of the school, Professor Siladitya Bhattacharya.
Okay, thanks very much, Katrina. I hope everybody's had the chance to digest the somewhat complex instructions, but thank you for that introduction. Good evening all, it's a great pleasure to be here. And the way I think we are going to do this is I'm going to do a presentation of roughly 25 minutes thereabouts, which will then leave some time for me to be joined by some of my colleagues from the medical school to take any questions that you might have. Okay. So thinking about the future of healthcare, we're clearly at a crossroads here because we've moved from what we used to describe as healthcare to health and social care, bringing in that wider dimension in which we operate as clinicians. And fundamental to that switch is awareness of the need to deliver the health outcomes that are important to the people we care for. That broader perspective also brings in and formalizes the concept of multi-professional working. We can't talk about the future without mentioning the digital revolution that we're in the midst of. But some things never change. We need to continue to make evidence-based decisions. But if you put all that together, clearly the role of future doctors is going to be quite different. We can have an estimate about the sort of things doctors might do in the future. So there are some known unknowns there, but equally, there are some unknown unknowns in terms of how things might change in the next couple of decades. Some things, however, remain the same. Our mission is to deliver evidence-based medicine that is focused on the needs of our patients. And interestingly, people dichotomize between the two concepts. When we talk about patient-centered care, we talk about patients as equal partners in clinical decision-making. We talk about health outcomes which are relevant and which accommodate the values and preferences of our patients. But in reality, if we go back to David Sackett's definition of evidence-based medicine, these things were always there. The bit that most people tend to focus on is that red bit here that talks about relevant scientific evidence and legitimizes this headlong rush into systematic reviews and meta-analyses, whereas in reality, that's only a third of the component of evidence-based medicine, and the other two parts are just as important, one being clinical judgment and the other being able to accommodate clinical decisions to the values and preferences of our patients. So it is about joint decision making based on judicious interpretation of a growing evidence base. And therein lies a problem, because of course that evidence base is growing exponentially every day, and the quality of what's published is very variable. So I think there is even more of an imperative for doctors of the future to be absolutely clear in terms of their critical appraisal skills and the ability to use the volume of evidence that they're faced with judiciously. Luckily for us, Health Education England has brought out this document very recently, which kind of maps out what the future doctor training pathway should look like. And I'm going to refer to some of this in the next few slides. So the challenges that we face in terms of planning education and training for the future is to align our training with healthcare delivery models which are fit for purpose today as well as tomorrow, to recognize that it's all about the patient and the patient expectations of this patient-doctor relationship continue to evolve. I've mentioned the growth in the literature that we have to rely on to guide our decision making. I've also mentioned the need to incorporate technology, but to do it properly, and to understand where the limit of our reliance on technology are, so that we can decide when we actually need to see a patient face to face and not just rely on digital methods of communication. Our future challenges include the need to consciously adopt a more inclusive approach. And the last is common sense, to align undergraduate teaching with postgraduate medical training as a continuum, because ultimately it is about training the next generation of clinicians to be better at what they do, but also to be able to cope with the challenges that I've just spoken about. So what do we need to focus on in terms of educating our future colleagues? I think communication remains absolutely critical. This is communication with patients of today, of the future, and also communication with other health professionals, with each other, with a multidisciplinary team. I think it's absolutely important that we look very critically at the super specialization that's been a hallmark of the late 20th century. And in this new century, rediscover the need for a holistic approach to a patient, this tension between generalist and specialist skills, and the reassurance that a patient gets from talking to one doctor rather than be a subject of a multidisciplinary team conference involving 5 doctors to map out a treatment plan for one patient. Team working remains absolutely critical, as does the learning to learn piece, which is all about not just absorbing information that we already have today, but the ability to plan for collecting and using information in the future. The other thing also is to think globally, because we train doctors not just to practice locally, but also across the country and beyond. And as in everything else we do in education and other areas of life, think about sustainability, both in terms of the environment, the economy, and society as a whole. The document that I mentioned about training doctors of tomorrow, if we are to believe the qualities and roles of the future doctor as set out in this document, seem quite impressive and utterly overwhelming. So in terms of qualities, we are looking for scholarship, we're looking for applied wisdom, i.e. knowledge accompanied by compassion, competence, a focus on accuracy and safety, the ability to involve patients in decisions, the ability to signpost appropriately, and the ability to give time to patients when they need that time. And the roles of the doctor, some things again don't change. So there's a role in terms of advocacy. There's a need to see the patient as a whole, so generalist skills, a decision maker or rather decision enabler, to be a leader in terms of making decisions where perhaps the evidence trail runs out and there is need to provide support and guidance to a team, and a role as a counselor. The pandemic has accelerated some aspects of the things we perhaps thought we needed to focus on in the next decade. So online and telephone consultations are here to stay, but just as it's important to know when to use them, it's also important to know when not to use them, and I think we've learned that as well. There are some situations where nothing but a face-to-face consultation and a hands-on-the-patient approach, nothing but that will work. We've learned to use new technologies, as have our patients. And I think we've had to work around some of the traditional barriers that have held us back in the past. Some things have become simpler. And part of that has been our willingness to have a cross-sector team-based approach around the needs of individual patients, rather than thinking around processes and how they suit us as care providers. What we've also learned is a digital approach can surface deep inequalities in terms of different areas of society that our patients come from and their varying needs. It's also taught us to focus on our own well-being and the well-being of the groups we lead. So how must education and training adapt to these changing needs now and in the future? I think we need to teach shared decision-making and that shared responsibility piece within our communication skills teaching. I think we need to go beyond just mentioning and paying lip service to wellness and prevention. That needs to be front and center in terms of our teaching. That means quite a major shift from our traditional emphasis on treatment of complex illnesses. We need to understand the needs of communities, including assets within the community, colleagues within the third sector. So it's almost this full spectrum from community to global in terms of the way we approach wellness, illness, and healthcare. Nothing can be delivered without a culture of well-being, and I think we've seen how important that is when we are under pressure. I think understanding context is really important, and part of our training must include that in terms of local health populations, different cultures. And we can't get away from digital, but it is about learning and actually learning for excellence in digital communication skills. It's not something we've been used to in the past. We've kind of learned along the way, but we now need to share that with the people that we are training for the future as well. So the Topol report a few years ago mentioned a number of top technologies, and it's interesting to see how some of them are already in common use now. So telemedicine, smartphone apps, sensors, wearables in some cases. Others, such as writing the genome, are still in the future. We're not quite using that. But certainly electronic health records bring in a whole set of opportunities, and we are just working our way through some of those for the future. Multi-professional learning is very much a part of everyday student life now in medicine to a varying degree. But I think what's really important is that we are aware of the evolving professional roles within a multi-professional team, how we link that with effective care delivered in the community, particularly at a time when footfall in hospitals and in primary care settings is much lower than it has been in the past. That's where teamwork and shared responsibility, but also clear understanding of every member's responsibility within a team is really important, as is communication. But all that amounts to nothing unless we keep the consumer, the patient, right at the heart of everything we plan in the training scenarios that we conceptualize, and also in that crucial interface between training scenarios and real life settings. We're also well on our way in terms of simulation training. It's already an integral part of what we do. It has come to the fore in recent months simply because of the different way in which patients have used health services, both in primary as well as secondary and tertiary care. And there are a number of components which we need to develop even further in terms of procedural competency training, scenario-based training, and of course, working with other professional groups. One area which I think will be very significant in future is our ability to effectively organize remote monitoring and delivery of care. And again, the technology is there. I think what's really important is how we roll it out and how we use it and how we train people to use it in future. We're also choosing our students in different ways. We have a well-articulated pathway now. We have new ways of getting students who otherwise might not have come into medicine to get into this route. But we need to do more. We need to make medicine relevant to students, schools, families who may not necessarily have thought of medicine in the first place. And we need that absolute clarity of vision so we can engage with these different groups of people and also take active steps to implement the strategies for leveling up inequalities within society, geographical differences that act as barriers to its entry in medicine. Something that's become really important in the last couple of years has been a well-documented strategy for inclusiveness, not least because a sense of belonging is absolutely vital to any member within a functioning healthcare team. Understanding different perspectives gives strength to our decision-making, and it's because of that, if for no other reason, that we must embrace equality, diversity, and inclusion as an integral part of our curriculum, and also link it to a global approach in terms of medical education. We've had some experience of this locally. Our students wrote an open letter in 2020 raising concerns about instances of race inequality. When we spoke to them, they mentioned a number of different factors, including a sense of otherness, of belonging or lack of. They pointed out the need for training and awareness of race literacy, They highlighted the importance of decolonizing our curriculum and pointed us towards areas of intersectionality, and also made us all aware of the microaggressions that they face in everyday life. We learned from them that there are challenges with raising concerns. It's a difficult area to talk about, but also gave us many constructive suggestions and engaged with us when we tried to improve our local environment. As a result of this, we've taken a number of actions, and I'm just going to run through these very, very quickly. We now have an anti-racist strategy, not just in the University of Aberdeen, but also within NHS Grampian that's being drafted. We've signed on to the BME and Advanced Higher Education Charters for Race Equality. Within our school, we've appointed a number of race equality champions and now have equality, diversity, inclusion co-leads for our school. We've rolled out advanced training beyond the standard EDI training that staff are encouraged to undertake. And we created a joint task force with colleagues in NHS Grampian to tackle this head on and come up with ways of making it easy for people to raise concerns, and also a feedback loop so that people can be told what the outcome of their initial discussions were. Coming back to teaching and learning for the future, we've spoken about how our teaching should evolve, but how should the environment within which we teach change? So if we're talking about simulation, we're talking about multi-professional, we clearly need designated areas where we can roll out this teaching in future. We need a digitally enabled health and learning system, but equally, we need an enhanced mechanism for high quality hands-on clinical training. And that brings in the tensions we face about placements for students, because we have a dispersed campus, not just in Aberdeen, but across much of Scotland. And how do we introduce that quality within the limited hands-on clinical training that students receive at the moment and probably are likely to receive in future? Given everything I've spoken about so far, the environment has to understand that we can only go forward with an active partnership with patients and the public. And through it all must be an acknowledgement of the need for an inclusive culture, as well as a focus on innovation, because we need to innovate for the changes that we know will come, but we also need to do some horizon scanning and be prepared to innovate for the changes that we can't see at the moment, but which are around the corner. So what are we doing in Aberdeen? We clearly have a lot of simulation multi-professional training going on at the moment. We have a dispersed campus. You can see all the dots all over. This is where our students learn. We have an emphasis on communication skills, and we are ramping this up in different ways. We already encourage students to take time to go through selected components where they develop skills in critical appraisal, evidence synthesis. We have a GP enhanced pathway for students. And we use digital technology for communication, but also for education. I've mentioned widening access, and I think it's important to highlight also our stakeholder partnerships with students as well as patients and the public in planning some of the ways in which we are going to deliver our teaching and learning now and in the future. So I said 25 minutes on there now. So in planning for the future, I think if I draw the points that I made together and in a summary, right at the heart of it is a patient-centered holistic approach, our ability to understand and adapt to future challenges. And we've shown that we've done that when we've been required to respond to acute situations like the pandemic. Horizon scanning to inform future innovation is going to be absolutely crucial in any strategy that we develop for the future. And it will all rest on our use and appropriate use of technology. So again, learning when technology works and when it does not, and we absolutely need that face-to-face interaction with patients. Critical appraisal, implementation of high-quality evidence, and the lifelong learning, which will then transition into CPD for the future, I think is absolutely important. But all that will only achieve the goals that we set ourselves if we do it in a culture that's wholly inclusive. So just to finish, I think to plan the future, we need to look forward, and the thing to avoid, which is what I hope this picture illustrates, is looking at the rear view mirror when we are planning for the future. Thank you all very much, and I'll stop sharing now.
Thank you so much for that. Sorry, my video has been a little bit slow just now. But just to let you all know, hi, my name is Nicole. I work in the Alumni Relations team, and I specifically work with the School of Medicine, Medical Sciences and Nutrition. So I think you'll all agree that was a really, really interesting update about the school. As Katrina said at the start, we're going to give you two options for how you can participate in this Q&A that's about to start. And one of them is via the chat box, which I had posted a message in at the start, encouraging people to leave their comments and their questions. If you haven't located that, you just need to click on the purple tab that's sticking out the side of your right-hand screen. And then once you open that, you'll see that there is a chat begun, and you can write any comments, any questions in there. But my colleague Chloe has also switched on your ability to turn on your camera and microphone. So if you prefer to ask your questions in person, you're very welcome to do that. All we ask that you do is that you raise your hand. So if you look at the bottom of your screen, you should now see a small microphone and a small camera icon, and then also a small raised hand icon. So if you'd like to ask a question in person, please simply press the raised hand icon, and then we'll call on you to speak one at a time. We just ask that everyone follows sort of meeting etiquette, and that you keep your microphone muted unless you're actually speaking. And as I said, you can also type your questions into the chat. So I'll give you just a moment to start thinking of the things you'd like to ask or get a bit more information on. But while we're waiting, I'll ask a quick question. You had mentioned about how things moved rapidly into doing telephone and video consultations, and that becoming kind of the norm now. How challenging was that to implement into the teaching side? Because I imagine that had to become part of the teaching very quickly. And how difficult was that to make a reality?
Thanks for your question, Nicole. Before we get into the answer, could I introduce my colleagues who are here? So we've got Rona Patey, Colin Lumsden, and Christine Kay, and I'd like to welcome them to this session. I know they're here. Not least because I'm hoping that they're going to field some of the more complex questions for me. So I'll start off the answer to your question to say that by saying that I think for us it was a bit of a challenge as practitioners to get into the video consultations and the telephone consultations. And clearly we did that initially keeping clinical service in mind, but then quite rapidly realized what a challenge it was to do that and teach at the same time. So it's brilliant that Colin's appeared, because I was hoping he'd pick up the answer from this point on. So over to you, Colin.
Okay, thanks, Patty, and so nice to see so many people here. Okay, so yes, an absolutely enormous challenge that came up on us at pace. Clearly, we were unable to maintain medical education for our students in a face-to-face setting. I reflect back on the beginning of the pandemic, when video consultations were virtually unheard of. We still talked about them in kind of hallowed terms of things that were possible in the future. And they very quickly became the norm. The use of Near Me became almost immediately the norm for our whole way of practicing. So the first challenge was allowing our students to get into those sessions. And I think that was a fairly smooth task, actually, because I think people recognized that we had to continue medical education in these challenging times. And we were able to get them into sessions. Probably the bigger challenge was finding them a device on which to watch, to engage in these sessions, because if you can imagine in the hospital, the amount of IT equipment that was available for students to use was extremely limited or non-existent. If there were multiple devices that they could use with functioning webcams, they weren't allowed to all go in a room like they used to. You know, the occupancy of rooms was vastly reduced. So I had to seek solutions to this, and this is one of the drivers behind our iPad program, which we actually delivered at very short notice last summer. So for context, each of our year 4 and 5 students now have an iPad mini that was delivered to them last year. And this allowed them to join in with many of those online consultations. So we had outpatient online consultations. They had access to MDTs. Ward rounds were happening on Microsoft Teams as well. So it allowed them absolutely to gain access to this. It wasn't without difficulty in that we had to get information governance clearance for them to be able to access these sessions, which we were able to do. And then we had to get clearance for them to look to access them from their own devices, because prior to the pandemic, the only way that you could do video consultation was via an HSG or any NHS device, which clearly we couldn't provide to all students. So that was a huge challenge. I think my own recollections and reflections on that process, it's a very different way of practicing, and a difficult thing to teach students if you don't have that background memory of many years of seeing patients face to face. So I don't think we have the solution or the answers yet as to how we do this. It's certainly a stream of research that has been started within ASME, actually. I proposed a stream of research around this about how we teach students remote consultation and how we assess it, because remember, we had to assess students on their ability to communicate and take histories on online platforms with virtual patients. So a huge challenge. Very happy to follow up any questions that might come from that.
That's great, thank you very much. We'll move to the next question. We've got somebody with a hand raised. So we've got Mike Gibson. Mike, if you want to turn your camera and microphone on, or just your microphone, you're very welcome to do so, and you can ask your question aloud.
Just turning the microphone on again. I have a fairly fundamental question. I'd like to ask what your view is of the future role of the doctor. I'm a bit of a dinosaur. I've gone through 50 years of having my position as a doctor consistently undermined by government, giving away my roles to cheaper practitioners. And I wondered how you can envisage what we'll be left with in the future. If I can give you an example, the Surgeon General in the Ministry of Defence is neither a doctor nor a military person. He's a hospital administrator. So thank you very much.
Thank you for your question. I'll start off and then I'll invite my colleagues to join in. I mean, this is a personal view, but I suppose we are working in multi-professional teams. There's been task shifting, so many of the tasks previously done by doctors are being taken up by other health professional colleagues. But I suppose the two things that the doctors of the future will be called on to do are, one, make complex decisions or decisions in complex situations where the guidance and the evidence trail runs out. And anybody practicing medicine will know that this happens on a regular basis. And the second, I suppose, is to innovate in terms of complicated, difficult interventions. And I'm talking about surgical procedures, I'm talking about radiological procedures, particularly because you can see how the landscape has shifted and interventional radiologists are doing things that couldn't have been conceptualized in the past. So those are two examples, but I wonder if I could bring in colleagues now. So Rona, what are your thoughts?
Thanks, Patty. I mean, I think that the role of the doctor at one level remains exactly the same. When you're there in front of a patient or when you're talking to a patient, it is absolutely about your interaction with that patient. But I think that we have another role, and that is at times leading and at other times following that multi-professional team that the patient actually needs to get the best outcome. And so I think now we need to know an awful lot more about what our colleagues can contribute to care, so that we can direct patients to others at the right time, so that we can get the very best outcome for patients. I think it's just it can't just be us by ourselves. But at the end of the day, wherever you are, it is about your interaction with a patient and finding the best outcome for that patient. And that still holds. I think the doctor does have a role as a manager, and I think it's really important that we take part in clinical management, because the best management requires that you know what is required at the coalface. So it's important that doctors do that. But the vast majority of the work that we do is working with patients and working with teams to make it work for patients. But that team is ever more broad, and it includes the third sector now. And in the past, we didn't include that in the curriculum at all. And yet students will have to understand when they graduate how the third sector is such a critical part of care in the community. So I guess those are my thoughts about it. Some of it has changed a lot and some of it hasn't changed at all.
That's great. Thank you so much for that. I just want to quickly read aloud a comment that actually Rona had made in the chat, just for those that hadn't seen it, and just to add to Colin's earlier comments. Everyone was buying digital technology at that time, and they were very fortunate to be able to obtain these for students, and that our NHS colleagues really prioritised and supported making this happen despite all the considerable pressures they were contending with at that time. So that's really wonderful to hear. And we've got a written question here that I'll read out for Alan Fraser. The necessary changes forced on care delivery by the pandemic, especially in primary care, have been very unpopular with many patients, especially the elderly and vulnerable who need services most. How can we involve the most needy patients in the way medical services are delivered and students are trained to deliver those services, taking into account patient feedback?
No, thanks for that. And I think I kind of referred to that when I said that actually I think the needs of the patient need to be absolutely fundamental in guiding any strategy, not just for healthcare delivery, but also education. In terms of how we are doing it in a practical way, I think maybe if I could open that up to Rona, Colin, and Christine, any thoughts about how we are picking that up and building that into our curriculum. Maybe start with Rona.
Oh, okay, thanks, Patty. I mean, I think it's such an important point, isn't it? And I know personally that there are a great many patients who really, really want to see their doctor. They want to see a real person, and we cannot underestimate that social part of the consultation with patients and how much it means to them and how important it is. And I think we're going to have to become really expert at when it's appropriate to have a telephone consultation, have a video consultation, and when it's absolutely critical that we aim for a face-to-face session with patients. And that's something that many of us are still learning as we go along, and I don't think we're the experts that we will be in the future, but we already are exploring that with students in the curriculum. Because of social distancing and because of other COVID measures, our assessments of students actually include some face-to-face activities, and they include some near me or telephone consultations. So we're mimicking that both in the teaching and in the curriculum going forwards. But learning how we do that, how we spot a red flag when we're talking to a patient on the phone and realise actually this is somebody we need to call in to see. We've had that initial telephone consultation, but we need to make an appointment to see them. I think we're getting quite quickly more expert at that, and that will be rolled into the curriculum. And that's why we need real practicing clinicians involved at all times in the curriculum, teaching students so students can learn from their expertise and take that forward. So those are my initial thoughts. Maybe I'll pass on to Colin for his thoughts.
Okay, thanks, Rona. I think we've all seen the backlash of late, primarily directed towards primary care. I speak as a clinician, I speak as somebody who's heard this backlash firsthand, and as someone who's married to a GP, so I've seen from multiple different angles. Look, I think there are a significant number of people who want that face-to-face interaction. That's absolutely essential that they're able to access that. But there's also a significant amount of the community quite happy with a video consultation. I probably would count myself in that group at this moment in time. So I think it's just trying to find that balance that works for everyone. I think that a video or phone triage is probably going to be the norm. I don't think you're going to be able to go straight in to have a face-to-face consultation without speaking to someone before that. So I guess it's just being aware of those challenges, being aware of the public perception. I must defend my primary care colleagues in that very often their practices aren't set up for appropriate distancing in waiting rooms. So when they get someone in, they do need to come in and see someone without sitting in waiting rooms for extended periods of time. So you're right, Rona, we do have to bear this in mind, and it's probably one of the skill sets that we need to deliver, develop in our students, is that ability to triage on a video or a phone consultation. It's not easy, to be honest. And my reflection on video consultations is people tend to agree with you on video consultations very, very quickly. Whereas in face-to-face, they might agree with you, but you can tell they don't really agree with you. And my consultations take twice as long in person as they do on video. So I think that's a really interesting thing that we'll have to see going forward.
Super, thank you so much, everyone. I'll just read a comment from Mike Gibson on that topic as well, which says, but triage should be done by someone experienced and not a receptionist. So that's something for you to think about there. We've got another question. Does the school envision having more partnership programs in the future, like the one in Sri Lanka?
I think from my perspective, as a university that sees itself as a global player, and we have an open mind in terms of where the next opportunity might be. But given the current circumstances that we are dealing with, we don't have any immediate plans for a partnership like the one in Sri Lanka. But Colin, I can see you on the screen. So any thoughts?
Okay, well, I guess those decisions are above my pay grade, and Professor Bhattacharya is very involved in these discussions, but I can bring my experience from a previous institution. So I came from the University of Manchester, where we had some very successful partnership programs. We had a partner program in Egypt, we had one in Saudi Arabia, and I believe a partnership that I just developed in another one in Egypt, the University of Alexandria has started as well. So I think they are really interesting developments, but they do come with enormous challenges. And I think some of the challenges we face with Sri Lanka were politically motivated. They weren't medically motivated or to do with the medical education, but there was a significant political element to that aligned to an election. And I know Rona was incredibly involved in this on a very personal level, and maybe she has some thoughts on that. But I'm not averse to developing partner programs elsewhere. Absolutely.
Thanks, Colin. Rona?
Thanks, both. I've put in the chat, I mean, I think your presentation, Batty, made the point that it's critical that we look globally for our curriculum. Our healthcare practitioners of the future have to understand the global context as well as the local context. And goodness me, we've just been through a global pandemic that has changed the lives of everyone that we know and will continue to impact on our lives for many years to come, I think. And the intelligence is that this is not the last global pandemic that we'll have to deal with. So it's really important that we both enrich the curriculum from a diversity perspective, but also that people understand that global context. So the Sri Lanka programme has enriched our curriculum, and we hope will continue to enrich our curriculum because of the close partnerships we've made there. And we've been talking a bit about technology, so the opportunities to link with other healthcare systems and other medical schools across the world, of course, now are much, much greater. And so there are different ways, perhaps, that we can do this other than just a program like the Sri Lanka Pathway. But I think I would agree with Batty. We would look seriously at opportunities to engage with other systems in the future. Right now, it's very difficult, isn't it? And it would have to be virtual at the moment. But finding ways to help students understand the global context in real terms, not just in textbook terms, that's important. That's part of our job in delivering the curriculum, I think.
That's great. Thank you, everyone. We've got someone with their hand raised. So Alex Grieve, if you want to turn on your camera and microphone and ask your question, that'd be great.
Hi. There we are. I'd clicked all the right buttons, but I wasn't getting the right answers. I'm a contemporary of Mike Gibson. I'll declare an interest straight away, so I'm presumably a dinosaur too. But what I wanted to do was shift the focus slightly and say that we're not starting with a blank canvas here, and we've got to tackle. It's a bit like trying to service the car while the engine is still running, because we've got the way it should be, and we've heard that very well explained and deployed this afternoon in the presentation. But we've also got to consider the way it currently is. And of course, when our young medically qualified people go out into the community, they're then dealing with people who've been qualified for many years and are very set in their ways. And sadly, these are the role models for what is going on. And to illustrate the point, I live in leafy Warwickshire. It's an idyllic part of the country. And it's a good place to practice medicine because there are good hospitals around, very good teaching hospitals, and general practitioners not overly burdened with patients. But the trouble is that they were trained in silos, and a GP is a GP and will share, not so much share something with a nurse, but delegate to a nurse. But when they say delegate, I think they mean abdicate. So they send it to the nurse and they never see it again. And the problem with this is that these elderly, well, the more established GPs are in an era which sees things like appraisal, revalidation, the CQC as burdens which exhaust their time and their patience and don't seem to help them in any way. These were designed as teaching tools. Now, my own view, having sat on college examination committees in the past, has been controversial. Namely, if we're doing things as well as we think we should be doing them, then we should be able to go back in and sit our examinations any day of the week and pass. Now, when you say that in an examination committee, people's faces turn white and they head for the exit. So if we look back to, say, Greenaway, now Greenaway is a few years old now, but I asked him in a public meeting and I said, there's no real mention of interdisciplinary training here. People are still being trained in silos. And what I was asking for would there be any opportunity for core skills, things common to each discipline, to every discipline, to be taught collectively or in collective groups? And that was battered to the long grass in no uncertain terms. But I think that's what's necessary, because in order for people to empathize with each other in a practical group setting as a team, they've really got to understand each other better. And bolting that on as an extra later won't work, especially if it's being bolted on by somebody who didn't start that way in the first place. So let me stop there.
That's a valid point, very eloquently made. I'm going to ask Rona if she has any comments to make.
Well, you raised lots of points in that, Alex, and I think this. If I think about your point about silos and people living in silos, that's something that there is real effort just now to go beyond. And Batty touched on the talk about generalism. We seem to be moving through cycles from having really training pathways pushing people to being specialists and to know ever more about an ever smaller area, to now the value of needing generalists and doctors who can take an overview and understand holistically what's going on with their patients. And one of the changes that we did a recent review of our Year 4 curriculum, and these points that you're raising were one of the things that we had in our mind about that, and the ethos of that Year 4, which used to be based on giving students a tour of specialties so that they saw all the specialties, I suppose all the career potential for them, has changed, and the focus now is on patients and patient pathways and pathways of care. And the placements that the students don't just focus on one specialty. They include, they focus on a pathway of patient care, so the students can see the range of not just medical professions, but the other healthcare professions that are required for a patient to have a successful health journey with whatever the problem is. So, for example, one of the new blocks in that is about long-term conditions and taking students through what is required to provide care for a member of the community who has a long-term condition, perhaps something that affects them from childhood right through to retirement age and way beyond. And so I think I don't suggest that we've got the right answer to the points and the concerns that you raise, but we are working hard to move in a different direction and take students out of that silo mindset, so that our graduates perhaps have a broader view. I hope that's helpful. I don't think I fully answer your point, but it's just an example of some of the work we're doing.
No, thanks, Rona. And I saw George Youngson's point about how do we make space in the curriculum to do that. So Nicole, sorry, I'm kind of usurping your position for a minute, but maybe this is an opportunity to bring in Christine, because you might want to talk a little bit about how we've adjusted our curriculum to try and accommodate this shift. Christine?
Right, yes, thank you, Batty. Yeah, space in the curriculum is really difficult. We have a very tight curriculum, and over the past 18 months, we have asked all of the blocks to look very, very carefully at what they deliver and try and hone things down, because there's always the tendency to add in more and to really focus the content and what's needed for an undergraduate. So Colin very bravely asked them all to cut their content by 30%, and we did achieve that. Maybe not the 30%, but there was some slimming down so that there can be some space for things like interactive case discussions, where we will maybe have both primary care and secondary care clinicians jointly delivering some sessions to the students, which tries to tease out how the whole system works together and how a patient goes from first presentation through to their pathway of care. So it hasn't been easy, but it's just forever trying to review and try to make sure that we're not taking things too far into the postgraduate curriculum level by the very keen teachers who do want to give their students that little bit extra. So it's a difficult job, George, and we're still working on it.
Thank you very much. I'm going to actually, there's a couple of questions that came in the chat and I'm going to read out. Rona has very helpfully sent a couple of replies, but I'm going to read them out just for anybody that's not seen the chat and also for the recording. John Simpson had asked, do you have the resources, patients, teachers, IT, etc., to match your aspirations? And following that up, Kelly said to add to that question, if you do not currently have the IT resources in place, are there plans to develop these perhaps alongside other areas in the university?
So maybe if I come in on that first, and then we can open it out to colleagues. So a very good question, John. As you can imagine, the response is pretty predictable. I think we would always need more resources to match our ambitions. So that's the answer in a single sentence. The reality is we're on a journey, so we have some technology. We would like a bit more. There are multiple strands that are available at the moment, and I think over time we'll be in a position to choose which ones are the best to go with. It's a very complicated field, and nobody knows it better than yourself. But I think we are well positioned to make the right choices. I think we do need more resources. Most of all, I think we need dedicated space because we have the kit, we have the students, obviously, and their numbers might grow in future. We obviously will need access to patients, and that's a separate discussion in terms of placements, but we need dedicated space, and we need to bring it all together to provide a genuine 21st century experience in terms of some of this IT and simulation skills. As you can imagine, I could talk about this for a while, but I'll stop and maybe bring in Colin this time around, because I know Colin has some expertise in this area.
Okay, thanks, Patty. A fabulous question and an enormous challenge last year. At my last institution, I spent 5 or 6 years trying to develop a blended learning curriculum, moving with technology. We had to do that in 3 months last summer. To give you an idea of the technology that we deployed, we had to make decisions at pace and deliver on time. And we basically had to use every piece of technology at our disposal. So we have our MyMBCHP bespoke VLE and student management system. We have our e-portfolio. We have a workplace-based assessment system. We had to employ Moodle, which is another VLE, to deliver our content. And we also use the institution's VLE, which is Blackboard Collaborate, which is what we're on now. So access to technology has never been the main challenge. The challenge we have now is we have too much technology and it's a bit confusing for everyone. So now we need to rationalize down into a coherent system that is very transparent to students and teachers and not overly complicated. So that's our main challenge at the moment. You also mentioned, do we have enough resources? Of course, we never have enough resource. We do have an amazing faculty of staff within the university and also in the NHS who have continued medical education through the entire pandemic. I think the thing that's the biggest premium at the moment is patience. You know, we've come from a position where students could see as many patients as they like at any time they liked. That is very, very different now. So they are at a premium. The access to them is at a premium, and that is the work we're doing at the moment, is perhaps timetabling a bit more, planning their experience and their access to patients a little bit better. So that's a big challenge we're facing at the moment.
Thank you very much. We've got a raised hand from Katrina. Katrina, do you want to come and ask your question?
Hello, sorry, got a little bit of delay getting the camera on there. I hope it's okay for me to ask a question. I am not a medic, but I was really interested in the point around training future doctors, future medics in prevention as well as treatment. And I wondered if the team might be able to expand on that a little bit. It's something that I find personally really very interesting.
Okay. Rona, do you want to go first?
Absolutely, Batty. And I mean, I talked a little bit before about our review of year 4, which is a critical part of our curriculum. And so preventative medicine and encouraging communication that supports prevention and good well-being behaviours for patients, and that being a critical part of the consultation is a core part of the curriculum now. I think it was always there, but it's now embedded right through the curriculum, through different topics. So I think that we could do better on that. I think we could always do better, but I think students are taught it from the very beginning. So our first year students are taught that as an implicit part of their history taking when they first start taking histories in term 1 of year 1 now in medicine, when they start talking with their volunteer patients, when they learn how to ask about the social history and how to give advice and make suggestions about any changes to people's social history. And then it builds from then on. So it is there right at the beginning. Does it always get the right emphasis, Katrina? Probably not. We can probably do much better on that. And I do think that's one of the lessons that we may, I hope, have learnt from the pandemic, is about the importance of public health. Public health has become really, it's achieved celebrity status in the UK because of the pandemic. And I really hope that can help drive interest in public health and the importance of systems for prevention, as well as individuals' behaviours with regards to maintaining their well-being. So it's a good question, and it's a question it's worth asking us regularly so that we keep thinking about it. Thank you.
And Christine, you've come in on the chat panel and mentioned some initiatives that the students have led. Do you want to come and talk about it so it's visible and audible to everyone?
Yes, thank you, Batty. So this is something we started a long time ago when Hamish was leading the curriculum. I think Hamish is here tonight. So we've had a number of summer projects supervised by our faculty where students input their ideas. So over the past couple of years, the first year they really focused on, for all of our systems, how to make the teaching, which was being recorded by the clinicians, more interactive. So they did lots of quizzes and other interactive skills things for the students to help them engage and get more out and test themselves on that delivery of online lectures. And then they've also helped with some of the work, Batty, that you mentioned earlier, following the open letter. We've had students working particularly on ways to introduce more diverse resources into our teaching, either quizzes focusing on this, or other developments, buying new material to help in clinical skills, or coming up with some sort of case-based scenarios. So that's been really fruitful during both the online delivery, and now that we're back to face-to-face sessions, the students are continuing to help us deliver some of these sessions, some of these difficult sessions where if it's only staff delivering it, it sets a certain tone, but if it's more senior medical students talking to them, they can relate more and really seem to be taking that message home. So it's ongoing work. It has been supported by donations from the Development Trust to the school actually to have this expanded number, and we're really grateful for the support that came in to allow us to do that, because it's helped us greatly, and it's also helped the students because it's given them some experience of an educational project which might lead to things in their career in the future, and it's also given them a bit of a bursary over the summer period to tide them over. Thank you.
That's great. Thank you so much, everyone. Mike Gibson's got another question in the chat. So have you been able to learn from what other medical schools have been doing? How much cooperation is there? I would hope you are not doing this in a silo.
So the straight answer to that, absolutely not. So we work closely with other Scottish medical schools within the Board for Academic Medicine in Scotland, and we work with the Medical Schools Council. And I think, Colin, you're away to join other medical school representatives very soon.
Thanks, Patty. I think there has never been greater cooperation amongst the medical education community. My thoughts about moving to Scotland is that we have an incredibly collegiate national group of medical schools who share resources very readily. But at the beginning of the pandemic, we were all rushing to try and develop our online curricula for the last academic year. And actually the sharing was quite astounding, to be honest. So there was a group set up by the Medical Schools Council where all universities shared the resources that they had available to them. Now, that was a little bit difficult to implement because all the resources were on various different systems and they weren't all interoperable. But certainly we did learn from each other. To be honest, the peer support was absolutely amazing because we all faced the same challenges. That forum still continues to ping through with multiple communications. I mean, the latest one was around the requirement to be vaccinated in England. So that's going to be a huge challenge in England, that if you're not vaccinated, how do you continue being a medical student? So thankfully, we don't have that in Scotland at this moment in time, but it's just an example of the information sharing that we've had throughout this last 18 months, and long may it continue.
Thank you so much. And we've got another raised hand. So Kelly, do you want to ask your question?
Hello, I'm not going to subject you to my camera because I've got some cats flying around the room at the moment. But I just wanted to add to Christine's comments around the bursaries. I need to say that although the summer bursaries came to the students via the Development Trust, we were only able to provide that thanks to some really kind donations which were made by alumni and friends of the university who wanted to support students in their studies. So it didn't actually come from the Development Trust, only through the Development Trust with our thanks.
Thank you for sharing that, Kelly. We've got a couple more questions. Chloe was asking, what are the key research focuses at the moment? And Rona had mentioned that technology was obviously quite high up on the list, but I'll let you, the team, answer that one.
So I'm interpreting the question as key focuses for research in medical education, and then maybe pass that over to first Rona, then Colin and Christine, because I think all of them will bring slightly different perspectives to this question.
Thanks, Patty. I'm not going to put my camera on because I keep getting kicked out of the of the session, which is frustrating. There are many questions, so I will give a couple, but I'm sure that Colin and Christine will give a couple more. I mentioned the technology, but it's really about how to use the technology. When's it effective? You know, I mean, it's fun to use the technology, but when does it really make a difference? And there is a lifetime of research in getting that right. We have some strengths in terms of medical education research locally. We've done a lot of work, and some of the key things that we've worked on have been on career choices for medical students, on differential attainment, and that's really important to understand if we're going to pursue an inclusive agenda going forward. So we're really very passionate about that. And Batty mentioned our widening access strategy, which has been really successful, and we are working very hard on following those students, trying to understand their journey through healthcare so that we can share the learning from that to improve the success of every student going forwards. But there are a great many questions. So maybe I'll pass on to Colin for his favourite topics for research, and then Christine.
Hi, Rona, you pinched all mine, I think. Absolutely, we're starting up some significant work around widening participation. A key interest for me is around a lot of the bias that there is around this group of students who we welcomed into the medical fraternity. There is an assumption that all widening participation students are going to end up in primary care. There is an assumption that we are setting up them up for failure, which is very patently not the case. So there's definitely work we want to do around that. You mentioned about career intentions. So if all widening participation students are not going to end up as primary care physicians, what are they going to end up as, and how do they make those decisions? Are there certain specialties that are more inclusive, that are more appealing to students from different backgrounds? So that's something that we are actively looking into. We have a significant piece of work around workplace-based assessment. So we talked about iPads, we talked about the use of technology. One of the main drivers was we weren't able to have an OSCE examination, so we weren't able to have a finals OSCE examination in 2020. What we had to do was create a portfolio of evidence, which was mainly paper-based. And for those of you who know the study, Morag Simpson spent many hours and days pulling together this information so to collate a portfolio of evidence for each student. So we've implemented a system of workplace-based assessments with personalized dashboards that are available to students and tutors. We can track performance over time. So I think there's a bit of work around that in how effective that is in developing doctors of the future. You know, are we doing the right things? Are we looking at the right competencies? Those kind of things. So that's something that is of great interest to me. If you ask about resource, as ever, finding the time to do these things whilst delivering a medical program during COVID is extremely challenging. But I'm very hopeful that we will have a lead of cherry coming to us in the near future. Christine?
Yeah, okay, thanks. So Colin and Rona have told you about the sort of formal large-scale research projects that we're doing, some in collaboration with other Scottish schools, but a couple of sort of local things that we are researching or reviewing is probably a better way to put it, are about how we better support students on our rural and remote placements, and also re-looking at our Regent scheme and how we can achieve more consistency in the kind of support that Regents are able to provide to their Regentees. So there are a couple of the smaller scale things that we're working on in-house. Thank you.
Thank you very much for that. Kim Walker's also commented saying, we're also doing research on Scottish workforce wellbeing, including supporting educators. That appears to be it, I think, for questions. I'm just having a quick look to make sure there's no other hands raised, but I don't see any. And there's no more questions, I believe. What I'm going to do is, in case you think of something, anyone who's attending, in case you think of something that you would like to ask after the event, that's absolutely fine. I'm having some connection issues, I think. I'm just going to turn my camera off to try and stop that. Yeah, if you think of anything after the session, that's absolutely fine. You can send us an email and I can pass that along to the team for you. I'll pop our email address in the chat in just a moment. Before I hand over to Katrina to wrap up, I just wanted to ask if the team from the medical school had anything else they wanted to add before we close.
No, except to thank everybody for taking the time to attend, to listen to what we are doing, what we are thinking about, and to thank them for their insightful questions and comments. That was all I wanted to say. Thank you very much indeed.
Thank you. I'll pass you over to Katrina Allen.
Thanks, Nicole. Yes, I just want to say a huge thank you to Batty, Rona, Colin and Kay for your time this afternoon. It's been fantastic. And of course, a huge thank you to all of our alumni attendees for joining us today and for your great questions and comments. We really do appreciate it. Like Nicole says, there might be things that occur to you after the session has closed, so please do be in touch with us. She's going to pop the email address, I think, in the chat, but I think you know it all. You can just reply to any of the emails we've sent to you and it'll come to us. So just send us your questions and we'll be happy to coordinate with the colleagues in the school to answer them for you. So yes, thank you. Take care, everyone, and thank you once again for joining us. Good night.